Mr. President, friends, I'm really happy to be here with you and share my experience in orthobiologics and regenerative medicine. Although I'm a classical orthopedic surgeon and I love to operate, especially arthroscopically, knees and shoulders, the older I get and the more experience I get, I'm starting to feel that maybe it would be better to try to operate less. Of course, there are situations that you cannot avoid an operation, like when you have an ACL complete tear, you have to repair or reconstruct, but it seems that the future is regenerative medicine. We are talking about stem cells. Arnold Kaplan, who is the father of stem cells, he was the first one who named them mesenchymal stem cells, but now this name has changed. Now we are calling them medicinal signaling cells. And the most important is that this kind of cells, they can secrete a massive level of bioactive agents that they are both immunatory and trophic. So this is the main job that they are doing. You can take mesenchymal stem cells practically from every tissue. And in orthopedics, we are mainly using stem cells from bone marrow or from adipose tissue. Adipose tissue is an excellent tissue to collect stem cells and HVF. It's easy to perform a minor lipoaspiration, not a liposuction, lipoaspiration. You can take a large number of stem cells, and for me, maybe the most important is that as patients are getting older, stem cells are aging as well, but this is happening more in bone marrow than in adipose. We have the evolution of ACL repair in the USA after the work of Professor Martha Murray. Now we can safely, it seems so, but of course we need more time to evaluate it. We can repair with an orthobiological method a tear in the mid-substance of the ACL, and it seems that it's the first time that this method is going to succeed. So what we are doing, it's a minor lipoaspiration. It's easy to be performed even from orthopedic surgeons. And this is the lipogems procedure, in which you are not using a centrifuge, and it seems that avoiding using a centrifuge is much, much better for the concretity and the better biological response of the stem cells. So what we are doing, we're putting the stem cells in this special tube that has 5 balls of metal, and we are trying to break the clusters of the fat mechanically completely. So you see the movement. We are doing this movement up and down, and we can take a beautiful clear adipose stem cell in an injection and then inject it where we need it. We can inject hips for hip arthritis, 2 or 3 Kergren-Lawson, and now we have started using it in, not now, we have experience of 3-4 years of using it in Kergren-Lawson 4. So under fluoroscopy, of course, for hips, you can also use ultrasound, but fluoroscopy is even more accurate. We can inject stem cells we got from bone marrow or from adipose, and we can use it blindly in the knee, or in this case, you see that I had performed before an arthroscopy. You can use it by direct viewing of the joint with an arthroscopy. Here it's a very interesting case because we are talking about a middle-aged patient, active, that he's running, and he had a previous meniscectomy which led to a cartilage, let's say, focal tear, but obviously the whole cartilage is really destroyed. So the correct thing in this case should be to perform a double operation in the same time, arthroscopically of course, ACI for the cartilage, and synthetical meniscus for covering the defect of the meniscus. But this is a very difficult operation. Every patient is not ready to accept it. It has a very long rehabilitation time. So what we did was very minor lavage, because it's proven that lavage doesn't offer anything. So don't suggest to your arthritic patients just to have an arthroscopic lavage. It makes things worse, not better. And as you can see, we are rejecting stem cells under direct vision. What we also did, because the more you are dealing with a case, then the better you become, we also did a minor knee liposuction. So we obtained stem cells from adipose tissue from the knee, which is anatomically, of course, much closer to the area that has the problem. It's a quite easy operation to perform with still tumescent fluid and liposuction. So you can obtain adipose tissue stem cells from the knee as well. We did a flow cytometry analysis to the final product of what we've got from the adipose tissue. So we checked numbers, vitality, and the subpopulations of CD, which, as you know, for name something as stem cell, we have to have some special subpopulations, and we have to avoid some others. So we saw that our final product was really good. We had a vitality of 89%, which was important, and really good numbers without culturing, which is very, very important. We also did a 3 years analysis of our patients with pre and post questionnaires with COUS and IKDC. We asked all our patients to fulfill these questionnaires before the procedure, 1 month after, 6 months after, 1 year, 2 years, and 3 years. So what we saw was that we had 2 subgroups, 64 patients, mean age 61 years old. We are talking about knee arthritis here, Kjellgren-Olsen 2 to 3. So, and of course, Kjellgren-Olsen early 4. In early 4, the numbers were at the beginning, before the injections, 46 for IKDC, and the COUS score was 53. At 1 year, the numbers were excellent. In 2 years, they are starting to deteriorate, and at 3 years, they are still better than in the beginning, but it's obvious that the maximum efficacy of stem cells was 3 years. We had the same picture for Kjellgren-Olsen 2 to 3, which is mild arthritis. Much better scores at first year, still very good at the second year, and they're getting worse at the end of the third year. So we also performed an MRI, and a quantitative analysis MRI. And we saw that depending the degree of the focal lesion, the focal cartilage lesions, if it was outer bridge, late 3, early 4, we had a much better view of the cartilage after 3 years, after 2 years, and that was the maximum. The same was happened in outer bridge 2 to 3. So we can say that the best functional and clinical results we obtained at the first 3 years, and the best MRI and clinical results for focal cartilage lesions, we obtained them at 2 years. So we saw that there is a potential there, and maybe there is an evidence-based reason to use stem cells, bone marrow or adipose for early arthritis. We use them for partial tear in the supraspinatus tendon and for many, many other reasons. Recently, I just wanted to show you that we're starting using cartilage from the ear. This is auricular cartilage. You can obtain it very easy with punch biopsy. You take 3 very small pieces of cartilage, We put it in a special instrument with 600 blades, and you liquefied it, and then you got an injection, not with stem cells, but with progenitor cartilage stem cells, and then you can inject it in the knee, in the hip. The important thing is, and this is my most important message that I would like to give you, is that it's not just orthobiologics, it's not just PRP like we heard before, or stem cells. Something different is happening, and I got the picture that medicine is changing. I named that meta-orthopedics. What's that supposed to be? This is my own term. I call it meta-orthopedics. What I'm going to say is that what David Sinclair and many other important scientists, not orthopedic surgeons, said, that aging is not inevitable, and aging is not a biological procedure that we cannot avoid. Aging is a disease. Why I'm saying that, and this is really strange to hear in an orthopedic congress, and especially after stem cells. I'm saying that because I think we have to start thinking about orthopedic problems holistically, totally, instead of saying that the guy is getting older and older and then he's starting to have back pain and hip pain and knee arthritis, etc., etc. We have to see it that all these painful syndromes are just a consequencing of aging. Why? Because as we age, our stem cells are aging. And without functional, biologically active stem cells, we cannot really repair problems. As I said before, I'm not saying that we must not operate. No, not of course. There are many, many situations that we have to operate. But what we can start thinking is to see our patient as a guy who, the older is getting, more problems he's getting. And if we operate the hip, then we can have a problem in another joint. So the new era is talking about stem cells, about senescence, about senolytic drugs, about how can we help to rejuvenate stem cells. Senescence is a state in which cells permanently lose their ability to proliferate, but they don't die. They stay in this state like zombie cells, but they secrete substances that they can harm, and they can cause cancer and many other problems. Senescence is caused by DNA damage. It's called by disrupting autophagy that we heard before, which is a very important biological cleaning procedure. It can be caused by many, many things. I think future in orthopedics and in whole medicine is going to be how we are going to regulate epigenetics. Epigenetics is the piano player. If genetics, DNA, genome is the piano, the guy who is playing the piano is epigenetics. And the epigenome is responsible for what our DNA, who is not changing, what the DNA is going to express. Express means to form a new protein. So if we're going to have good orthobiological response, we have to rejuvenate the stem cells of an aging person. And you can do that through different mechanisms, because aging is caused by mechanisms like AMPK or mTOR of rapamycin. We have to replenish NAD, very important substance, to activate sirtuin proteins and to remove senescent zombie cells. So it's very, very important to start thinking before a knee arthroplasty, before a hip arthroplasty, before stem cells, to make our patient more biologically active, so our procedure is going to be more successful. So what we have to do is to increase sirtuins, that there are proteins that they can disrupt the mechanism of aging and illness. We can do it by drugs, senolytic drugs like quercetin, like metformin, it's okay, like metformin, and with exercise, with correct diet, and all these things. So, closing this presentation, I have to say that it's not just operating, it's not just stem cells, it's not just PRP and Golding and all these things. We have to start thinking a little bit differently. I'm not talking about beauty and wellness and longevity, I'm talking about healthy issues, how we're going to help our patients to have better biological ways to react in an orthobiological procedure or to an operation. Thank you very much.